So basically, you all are prepared already. So genetics is something which is very volatile. So my only endeavor is to get you into the groove for genetics for MRCP, number one. Number two, to catch hold of almost everything which is important for the exam. Number three, not to miss out on something which is important. That is also very, important for the exam. So we will just touch upon few topics. We'll just briefly try to understand them because in such a short span of time, whole of the genetics and the diseases associated with it, it becomes very difficult. So as far as the genetics goes, oh, you need to understand that in genetics you will get number one, the genetic basis of disease. This is the concept that is asked in the exam, number one. Number two, how to diagnose genetic diseases. And number three, which is a very weird thing, it is how to treat genetic diseases. And number four is miscellaneous. Miscellaneous is like pharmacogenetics, then screening for genetic disorders. Like every country will have their own set of recommendations and guidelines as to how to screen for genetic diseases. So just this, with this generic background, I would like to ask randomly, can anybody tell me what is the genetic basis of a disease? Broadly speaking, why it is important for us to understand the genetic basis of a disease? See, some diseases, they are inherited as a genetic disorder. Now, this is one. Number two is certain people are prone to certain diseases because they have genetic deficiencies. For example, G6PD deficiency. This is also a genetic disorder. Like some people who are hemophiliacs, they have genetic disorders, so they're more prone to develop bleeding disorders. Number three, certain cancers, they are more common in certain genetic disorders. Number four, certain structural diseases are more common in certain genetic disorders. So we as doctors, we have the responsibility to ascertain if somebody is carrying a gene or a chromosome which can affect the offspring or their own life in a particularly wrong fashion. Then comes diagnosis. Can anybody tell me how do you diagnose genetic diseases? Am I audible? All I'm asking is, if somebody can tell me how do you diagnose genetic diseases? You are preparing for MRCP exam. You already have certain amount of knowledge because all of you are doctors. So my question to all of you is, how do you diagnose genetic diseases? Anyone? Okay,
By
so you will, yeah.
screening the genetic deficiency, the genes, what we mentioned.
Yeah, how do we diagnose these genes? What is the mechanism? Like we order sodium, potassium, urea, creatinine, CBC, total blood count, LFT. What do we say that we want to get a genetic disorder tested?
The genetic mapping.
So we do a karyotyping
Yes.
and gene analysis. This is what is done these days. So you will enjoy this class uh, after having these questions in mind. Then, of course, how do you treat genetic disorders? That is another thing. And then we will see the miscellaneous pharmacology. Miscellaneous pharmacology means certain uh, enzymes, they are inherited and they have different, fast acetylators and slow acetylators. These are all genetics. Okay. So let's begin the topic with the biggest chunk of the genetic disorders, that is autosomal dominant disorders. Now, I always tell my students that there are two types of disorders as far as autosomal genes are concerned, which are autosomal dominant and autosomal recessive. The autosomal dominant diseases are more or less structural diseases. So wherever you will find a structural disease, no, there are high chances that the patient will have a autosomal dominant disorder. Then comes autosomal recessive disorders. Autosomal recessive disorders, they usually manifest as enzymes or chemical related processes deficiency. So they will have like some enzyme deficiencies are usually autosomal. Wherever it is a biochemical process related with it, it usually is autosomal recessive disorder. So let's begin our journey for genetics by autosomal disorders. So all you need is one mutated copy. So we all know that there are two chromosomes. So genes are present on both of them. One is from the father, one is from the mother. So all you need is a major single gene which is altered and it will manifest as a disease. A one mutated copy of a gene is sufficient. For example, A, this is a normal genotype. A, this is female, this is male. They marry, so everybody has A, we understand that. But now let us say the gene is so dominant that this gene became mutated. So we have A dash A and AA. So A dash A will be diseased. That means you will never have a carrier. Never a carrier. Why? Because even a single copy is sufficient for the disease to manifest. Hence, there will be no carriers in autosomal dominant disorder because the genetic defect is a dominant defect. Even if it is singly present, it will definitely cause the disease. Common examples are Huntington's chorea, Marfan's syndrome, familial hypercholesterolemia. So, let us go through the case scenarios to understand the process in a better manner. A 28-year-old man with a family history of sudden cardiac death is diagnosed with aortic root dilatation on echocardiogram. He is tall, he has long fingers, and there is a chest deformity known as pectus excavatum. What is the most likely disorder in this patient? Ehlers-Danlos syndrome, Marfan syndrome, Turner syndrome, or Loeys-Dietz syndrome?
Marfan's.
So this is Marfan's syndrome. How do you say that? Why not Ehlers-Danlos?
Cardiac defect, I think, is only for Marfan's.
Say again. Pectus
The cardiac,
excavatum.
the cardiac defect is not seen in Ehlers, I think.
Yeah. So aortic root dilatation, very aptly picked up. So aortic root dilatation is usually seen in this Marfan syndrome. Okay. So if I had to pick up something for Ehlers-Danlos syndrome, then what would it be? Because both of them, they manifest very, very similarly.
The lens subluxation will be
Wonderful. So lenticular subluxation. So if there was mentioned that there is a history of a repeated blurring of vision for which the patient has been diagnosed with some lens related issue, this will be Ehlers-Danlos. Okay. So this patient has Marfan syndrome. We will come to it that there is a mutation in specific gene known as fibrillin-1 gene, which is FBN1 gene, characterized by, as you said, aortic root disease, tall stature, and skeletal abnormality. Tall stature and skeletal abnormality, hyperreflexia, hyperlaxity, these are seen in other connective tissue disorders also, but aortic root dilatation is specific for Marfan syndrome. Okay. Can anybody tell me why Turner syndrome is specifically mentioned as a choice in this question? Now, as a student, you need to read the examiner's mind also. Why Turner syndrome is kept in this? Because
Yeah, they also have some cardiac related issues, is it?
Do they have a tall stature?
No.
Are they not tall? Turner syndrome? Turner is what, XO?
Yeah, 45 XO.
Yeah, so they are usually tall people, but they have aortic root issues. What are those issues they have?
The
So they usually
coarctation
have
of aorta.
coarctation of aorta. Yeah. So they have coarctation of aorta. So when you have similar two things in a question, then there are chances that some children, some student who have partial knowledge, they might pick up that answer. So it is important for you to differentiate. Every single word is important. In MRCP exam, nothing is taken for granted. All right. So the answer here is Marfan syndrome. A 45-year-old man with LDL. Okay. When I was telling you about the autosomal dominant disorders being structurally more, bent, that they are usually structural diseases, this brings to our mind, is there any non-structural disease which is autosomal dominant? Yes, it is hypercholesterolemia, familial hypercholesterolemia. So please remember that. And when I come to the autosomal recessive, I'll tell you some autosomal recessive diseases which manifest as structural diseases. They are exceptions. This is an exception. That is why I specifically kept it. A 45-year-old man with LDL of more than 250 milligram per deciliter has tendon xanthomas and a family history of premature coronary artery disease. What is the inheritance pattern for this condition? This is a specific question, has appeared in the exam so many times because
Autosomal dominant.
yes, so you will need to remember
Familiar
that
hypercholesterolemia.
yes, that familial hypercholesterolemia, although it is a metabolic disorder, but it is autosomal dominant. This is a rare thing. So familial hypercholesterolemia, it follows an autosomal dominant inheritance, severe LDL elevation, and early cardiovascular events. So this brings us to a discussion on autosomal dominant inheritance. What do we need here is a single copy is sufficient to cause the disease. A mutation in one allele of the gene is enough to cause the disease. Second, it has vertical transmission. Why? Because all the diseases will travel from parents to the children. Of course, every diseases, genetic diseases travel like this, but vertical transmission means the disease definitely will travel from the upper generation to the lower one. Equal gender distribution. There are no distinction between genders as far as autosomal diseases are concerned. We will come to that. 50% recurrence risk. An affected parents has a 50% chance of passing the mutation. These lines, they have come in the exam as ditto. 50% recurrence risk is seen in autosomal dominant disorder. What kind of disorders? Usually structural, like neurological disorder, Huntington's disease, neurofibromatosis, tuberous sclerosis. These are basically structural. You can say that, like in neurofibromatosis, there are tumors of the peripheral nerves, neurofibrillin 1 associated with cafeola spots, again something structure related, and Lish nodules, again structure related, something to do with the morphology. Tuberous sclerosis, there are facial angiofibromas, patients have seizures, and renal angiomyolipomas. Then skeletal and connective tissue disorders, like you perfectly picked up, Marfan syndrome. There is fibrillin 1 mutation, tall stature, aortic aneurysms, ectopia lentis, usually seen in Ehlers-Danlos. Ehlers-Danlos, hyperextensible skin and joint hypermobility. Achondroplasia, structural, short-sighted people. FGFR3 mutations, short stature due to defective endochondral ossification. Osteogenesis imperfecta, structural disease. Colia 1, Colia 2 mutations, brittle bones, blue sclera. Has somebody seen this movie called Dune? In that movie, there is a set of people who have, everybody has blue sclera. So this is how osteogenesis imperfecta people with blue sclera look like. Hematological disorder, hereditary spherocytosis, again structural, structure of the RBC is distorted, leads to hemolytic anemia. Disease is because of spectrin or ankyrin protein defects, which are important integral proteins. Von Willebrand disease, deficiency or dysfunction of von Willebrand factor. Cardiovascular diseases like hypertrophic cardiomyopathy. This is so important. HCM has a autosomal dominant inheritance pattern. Familiar hypercholesterolemia. Then other disorders, very famous ADPKD, PKD1, PKD2 mutations, familial adenomatous polyposis, APC gene mutation, numerous colonic polyps, retinoblastoma, RB1, eye tumors in gene, multiple endocrine neoplasia, where there are several type 1, 2A, 2B, and tumors of endocrine gland. Important points in autosomal dominant are there are variable penetrance. Some individuals with that mutation may not express the phenotype. So theoretically speaking, A-A should have the disease, but the penetrance may be variable. That means they will not manifest into the 100%. That totally depends on the degree of mutation in the genes. So genes also have a long pool of these nucleotides and nucleosides repeating. So sometimes, although the gene is mutated, but the type of mutation is different in each gene. De novo mutations can also occur without any family history. There is anticipation, that is, successively in down generations, the disease occurs early in age. For example, let us say in the first generation, it was 60 years. Second generation, the disease started at 50 years. In third generation, probably it started at 28 years. Specifically in Huntington's disease, hypertrophic cardiomyopathy, people can have disease at a younger age when they are inheriting this. So autosomal dominant inheritance, again, let us review. So single copy is sufficient, vertical transmission is there, equal gender distribution, and there's a 50% risk of carrying the disease. Then there is a variable penetrance, anticipation is seen. Although it's a genetic disorder, but de novo mutation will also manifest. Why? We understand it's an autosomal dominant one. So even if one gene gets mutated, the disease will manifest for 100%. Maybe it is less symptomatic or more symptomatic. That is not the point. But if one gene gets mutated either by inheritance or spontaneously, now coming to autosomal recessive disorders. The problem here is it is a recessive disease. So two genes, two are needed to tango. So both alleles of the gene must be mutated for the disease expression. For example, A-A will be a carrier. He will not be symptomatic. A-A will be symptomatic. For both the alleles of the gene must be mutated for disease expression. If just one gene is mutated, it will be a carrier. So two carriers have to marry to produce one diseased child. So there comes the role of genetic counseling and genetic screening. So these are the diseases that you should keep in mind, not for the knowledge of these diseases, but to prevent and counsel the patients so that these diseases, they don't get transferred in future. So the knowledge of these diseases is important, that you start looking for any elder in the family with similar symptoms, so that you can tell that, okay, nowadays people get married out of genetic counseling as well. We will come to that point where the nice guidelines and the NHS related rules regarding genetic screening and genetic analysis is concerned. Common examples, enzymatic diseases like cystic fibrosis, sickle cell anemia, phenylketonuria. So a 3-year-old child has recurrent pulmonary infections, failure to thrive, and bulky greasy stools. Sweat chloride testing confirms the diagnosis. What is the genetic mutation responsible for this condition? What is the diagnosis?
Cystic fibrosis.
And which is the gene involved?
CFTR.
CFTR. And which is the chromosome on which it is present?
Chromosome 6, sir.
Chromosome
6.
6. Okay. I thought it was chromosome. Okay. So cystic fibrosis is an autosomal recessive disorder, and it is caused by the mutations in the CFTR gene, leading to impaired chloride transport and thick mucus production. So they have stagnation of the thick mucus in almost all the tubes of the body, be it lungs, where bronchoria leads to plugging of the bronchi, uh, pancreatic ducts, where pancreatic secretions they dry out, become thick, and block the pancreatic duct, leading to pancreatitis, which is a recurrent pancreatitis. They are chronically constipated because again the same process happens in intestines. They also have infertility issues because in the fallopian tubes the secretions plug in the fallopian tubes. They are not accessible for the uh, this fertilization to happen. And same stands true for the males, where sperms get occluded in the testicular ductal system, whereby there is a plugging by the mucus and all. So, cystic fibrosis is so important. How do you diagnose cystic fibrosis, anyone?
Sweat chloride test.
So, yeah, sweat chloride test is important, which is sweat test, which is a gold standard for the diagnosis. So, CFTR gene is important. And it is autosomal recessive disorder. Okay.